Today the topic is on sarcoidosis, and I'll be talking to you over next 30 minutes about the epidemiology, pathophysiology, and different forms of uh, pulmonary manifestations of sarcoid, cardiac manifestations, and all manifestations I'll be talking to you over the next 30 minutes. And for introduction, sarcoid is a multi-system granulomatous disorder of unknown etiology, and most commonly affecting young adults, and presently most frequently it will present with bilateral hilar lymphadenopathy, pulmonary infiltrates, and then other system manifestations like skin manifestations and eye manifestations will be there. And the diagnosis is established most commonly by the clinical, radiological, and the histological evidence of non-caseating granuloma. This is the main thing in sarcoid is a non-caseating granuloma, whereas in tuberculosis you will get a caseating granuloma. I will also come to that part of the caseating and non-caseating, why tuberculosis overlaps with sarcoid and what are the studies. I will come to that in the later part of my talk. And sarcoid was first identified in 1869 and in United States of America, and there you have around 11 out of 1 lakh Caucasians will be affected, and 36 out of 1 lakh African Americans got affected by sarcoid. And coming to the age and sex distribution, and men and women are all ages are equally affected, and most commonly females are most commonly affected, and most common in adults between 20 and 40 age group. And it is also most commonly not seen in patients who are smokers, and it is more common in non-smokers. And HLA antigens, HLA-B8 and HLA-DR3 and HLA-CW7 are most common antigen presenting in the sarcoid. And prevalence is most common in black population, black Africans and black Asians, and it also runs in families. Sarcoid can run in families, and in environmental factors, sarcoid is more prevalent in non-smokers than a smoker. Coming to the pathophysiology, as I told, you have the antigen. The step 1 is the antigen exposure and internalization with presentation in the regional lymph nodes. So, this antigen will attach with the antigen presenting cell, and it will stimulate the CD4. That is the step 2, where its CD4 cells get activated, and there will be a proliferation of CD4 cells and Th1 polarization, induced antigen recognition, and the stimulation of activation of macrophage. So, this is the third step, where there is a circulating CD4 cells which with chemokines like tumor necrosing factor alpha, interleukin 12, interleukin 17 and interleukin 2, interferon gamma. All these things will stimulate the macrophage, and this macrophage will later on form the granulomatous formation, and this is a typical non-caseating granuloma will be seen in sarcoid. So, once in the presentation, they can present with a non-caseating granuloma, and then later part they will go for a chronic inflammation and fibrosis of the lung is the later stage in the stage 4 of sarcoid. So, this is the pathophysiology of sarcoid, and coming detailed explanation, this is the antigen, macrophage and the T lymphocytes which stimulates the interleukin 12, and the interleukin 12, interferon gamma and interleukin 2 will promote the Th1 response, which is responsible for the granuloma formation. Here you can see the infectious agents, organic particles and inorganic agents together will stimulate the antigen, and this will stimulate the TNF alpha, interleukin 12, all these things will stimulate the CD4 T cells. Will have T1 cells will be there and T2 cells will be there. In this you will get an interleukin 2 and interferon gamma, which helps in the formation of granuloma, whereas in Th2 cells, interleukin 4, 5, 6 and 10 will stimulate the formation of a granuloma, and sometimes these granuloma regress on its own and it will come in a resolution phase. Sometimes these granulomas can progress, and later on it lead on to the complete fibrosis of the lung. This is the pathophysiology of sarcoid, and there are the pathognomic feature in sarcoid is a non-caseating epithelioid cell granuloma is a typical form in cases of a sarcoid induced lung disease, or anywhere in the lymph node or all these places you will get a non-caseating epithelioid granuloma. What is epithelioid cells? It's a differentiating form of mononuclear phagocytes, CD4 lymphocytes and matured macrophages together form the epithelioid cells, and there are some inclusion bodies present in the granuloma. Sometimes that's called as an asteroid bodies, Schumann bodies, Hermansky's, Westenberg's bodies. All these are typical present in sarcoid. This also can present in some other diseases, but it's also one of the feature where you have to look in patients with sarcoid on by microscopy. And these in the lung, these granulomas tends to be perivascular or peribronchovascular or septal areas where there is a rich in lymphatics. I will come to that in the later part of my talk. And the granulomas sometimes may resolve or undergo fibrosis or a formation of a granuloma or a healed granuloma like lesions in the lung. So, this is the pathology of sarcoid, and these are the different cytoplasmic inclusion bodies. Schumann bodies are lamellated concentrations, you can see here, composed of calcium and protein, and asteroid bodies are eosinophilic inclusion bodies, you can see here. These are the eosinophilic satellite inclusion bodies, that's called as an asteroid bodies. Hermansky-Westenberg bodies, or it's mainly related to the extensive hemorrhage, and it largely represents, it's like a brownish lesions, yellowish brown oval lesion bodies typically seen here. So, this can also present in other conditions also. And the calcium oxalates is a bifringent crystals which is typical by electron microscopy view. It's a typical we can see in sarcoid. These are the different cytoplasmic inclusion bodies that you have to look in patients with sarcoid. If you are diagnosing of sarcoid, you have to look for all these things by microscopy.